You are now listening to MedEd Talks Cardiology, a Vindico Medical Education production. To view the CE information and claim credit, log into mededtalks.com and search Lipid Legends Season 2, or click the link in the notes section of this podcast. Now, here's your host, Dr. Underberg.
Hello and welcome to the Lipid Legends podcast series. This continuing education series is supported by educational funding provided by Amgen, Arrowhead Pharmaceuticals, and Novartis Pharmaceuticals Corporation. I'm your host, Dr. James Underberg, a clinical assistant professor of medicine at the NYU School of Medicine and the NYU Center for the Prevention of Cardiovascular Disease. I'm also the director of the Bellevue Hospital Lipid Clinic in New York City and past president of the National Lipid Association. Today, I'm joined by my colleague, Dr. Daniel Soffer, also a past president of the National Lipid Association and an associate professor of medicine at the Perelman School of Medicine, the University of Pennsylvania. Dan, thanks for joining us today.
Thanks for having me, Janie. It's great to be here.
All right. So in this Lipid Legends podcast series, I have the extreme pleasure of interviewing expert physicians and researchers on topics that are of current importance in the field of lipidology. Today, we'll be discussing key considerations for the assessment and treatment of patients with elevated triglycerides or hypertriglyceridemia. But before we get started, I wanted to just talk a little bit more general. And Dan, could you give us some ideas on how you ended up in the fields of lipidology? I know you're an internist by training, like myself, but how did you end up in the field of clinical lipidology?
I'd love to say that it was a well thought out plan, Jamie, from day one, but honestly, there was a lot of twists and turns and pathways that opened at just the right time. I think like a lot of generalists who finish their training and go into primary care, general medicine, they love everything they do. And I was one of those people who I just loved all the topics. But after several years, I knew I needed to sort of focus a little bit more. I didn't have that need early in my career, but I noticed it a few years into my practice. And I kept finding myself in programs that were about cardiovascular disease and lipid learning. And the more I learned, the more I wanted to learn. One thing led to another. The National Lipid Association started offering special training towards lipidology. At my home institution, a position was sort of created for me because a colleague knew that I had a particular interest. And there were circumstances that enabled me to be able to split my practice, not the least of which was developing electronic medical record keeping, which enabled me to be more flexible in which offices I was going to. You know, it really helped having that extra certification as a clinical lipid specialist early on. I was I wasn't in the first class. I think I was in the second class of lipid specialists who took that exam. And that opened up some doors with me. And then there was this guy, Jamie Underberg at the National Lipid Association, who kept asking me to do stuff at the NLA. And the next thing you know, I've done a whole bunch of different things at the NLA, wearing a lot of different hats, got a chance to see a lot of different things. And that was really very useful for me. And I was doing more in lipidology, and so much so to the point that 2 years ago, I was president of the association. And I actually, as I'm entering the final third of my career, I like to think of it that way. I've condensed my practice down to just a lipidology practice, and I no longer do primary care. So it was a transition. Sorry to draw out that story, but it was a transition, and a lot of it was natural. Some of it was structural. It is a field that sort of sucked me in. I have to say, one of the things that I was most enthralled by is the complexity of the physiology, yet it was very finite and learnable. And I really like that sort of combination, like a puzzle that you can complete, not an impossible puzzle.
I've watched your career over the years. I'm curious, of all those great things, what achievement are you most proud of?
I would say, being president of the National Lipid Association is, if it's not number one, it's in the top three. It's a great honor and a great opportunity. I got to hobnob with certain people that I guess I wouldn't have been able to do that with before. it's opened doors in terms of opportunities for me in communication with colleagues around the country and around the world, and given me experiences in ways that I wouldn't have otherwise dreamed of. And the only reason I hesitated in terms of, saying that was the number one thing is because the other thing, it sounds a little cliche and sappy, which is you and I both had the opportunity to live through some major changes in lipidology management. And, about a decade ago, when we started prescribing extremely powerful LDL lowering drugs, and we saw the expressions on our patients' faces when they came in to see the results after starting PCSK9 inhibitors, that ranks as one of the greatest things that I've ever been part of. Just even though I didn't develop PCSK9 inhibitors, we were part of the development program. And to see it sort of roll out in front of our eyes, it's been a tremendous change in our field. And I'm glad to have the opportunity to do that too.
So that's a great segue, because we're going to talk about triglycerides today. And we are on the cusp of a wave, I think, in the development of newer therapeutics and different ways of thinking about this entire disease space within the context of clinical lipidology. And so I think, as a good starting point, how do you define hypertriglyceridemia, the different levels, classification, and why it matters? Why is it important for us to think about elevated triglycerides? Because often people have dismissed triglycerides.
Yeah, I can actually remember being a medical student on cardiology service at one of our hospitals here, listening to cardiologists talking about how triglycerides don't matter. And then another one was saying, "Are you kidding me? They're super important." That was the early 90s. And I think you still hear people having the same conversation today. The levels of triglyceridemia are quantitative, and we have different nomenclature for describing them. But, we think in terms of mild to moderate, severe, sometimes extreme. And then in the extreme category, there's a sort of subheadings too. And different associations have different criteria. The numbers that I keep in my head are from the American Heart Association, American College of Cardiology, defining guidelines. And so in the fasting state, a triglyceride level of 150 milligrams per deciliter, all the way up to 499 or 500 milligrams per deciliter, is the range of mild to moderate. Levels above 500 milligrams per deciliter are considered to be severe. I was part of a research team recently where we separated out another category of extreme hypertriglyceridemia to correspond with the units that are used in Europe, the millimoles per liter. So we classified levels greater than 880 milligrams per deciliter as extreme, because it corresponds to 10 millimoles per liter. So it's a nice rounded number.
People often want to know where that 880 comes from. I think that's important information.
Yeah, we like rounded numbers. And the reason there's some distinction about which is important is it's 500, should it be 880? I mean, those are arbitrary rounded numbers, but they correspond roughly to a biological phenomena where at around 750 milligrams with a wide range is the level where the critical enzyme responsible for hydrolyzing fatty acids from the triglycerides found in lipoproteins starts to become saturated. So that was a mouthful. What I'm saying is that at around 750 milligrams per deciliter, plus or minus 150, that the enzyme that's responsible for pulling triglycerides off of lipoproteins doesn't work very well. So you get above that level and you go from bad to severe very quickly. And so that's why it's an important number. And though none of us use 750 as the key number for separating out what's high and what's not high. And I think it's sensible actually to use a number that's below that, like 500, because of that biological phenomena, to make sure that we're not in that range.
So we think about, obviously, concern for things like pancreatitis when triglyceride levels get above these levels you're talking about. But in the current guidelines, which are due to be updated soon, in 2018, triglyceride levels that were elevated were also identified as a risk factor for atherosclerotic cardiovascular disease. So is it that it does both, one, the other? What's your thinking on hypertriglyceridemia and ASCVD risk?
Yeah, there are a lot of medical conditions that are associated with hypertriglyceridemia, but as a causative factor, hypertriglyceridemia definitely causes atherosclerotic cardiovascular disease and acute pancreatitis, both. The relationship between triglycerides and the condition quantitatively is different. So for atherosclerotic cardiovascular disease, the risk for ASCVD starts to increase in a somewhat linear fashion from 150 all the way up to 500. And it sort of peaks as you get into that 500 to 1,000 range and reaches a plateau. So it stops increasing with triglycerides at that point. The level may still go up a little bit after that, but you don't get the same linear rise in ASCVD risk as triglycerides go well above 1,000, that you've already sort of reached the capacity of its potential to increase atherosclerosis. Whereas pancreatitis, it's very different. It's a continuous linear increase from a level of 150 milligrams per deciliter on upward. And the risk for pancreatitis increases the higher the level of the triglyceride continuously.
That's interesting. So when it comes to causality in ASCVD, is that the triglycerides themselves, or do you think it's something associated with hypertriglyceridemia that drives the risk of atherosclerosis?
Well, I like to describe it in three terms. So the triglycerides themselves are carried in lipoproteins, as you know, the triglyceride-rich lipoproteins. And as they circulate through the bloodstream, those particles will shrink down from their nascent size to smaller levels as the fatty acids are being hydrolyzed from those particles in the bloodstream. And triglyceride-rich lipoprotein remnant particles that are less than 70 nanometers in diameter can penetrate into the intima, where they participate directly with atherosclerosis the same way that LDL particles can participate. There's a direct result of the triglyceride-rich lipoproteins affecting atherosclerosis. The other thing is that there's an indirect effect, and your colleague at NYU, Ira Goldberg, has contested whether or not this is an important phenomenon. And I will say he makes a good case that maybe the fatty acids that inadvertently get released at the level of the endothelium may not have a direct impact on endothelial function, but indirectly, having high levels of triglyceride-rich lipoproteins may exacerbate some of the endothelial dysfunction for that reason. But there's clearly a third thing going on where endothelial function is being affected as almost like a bystander effect. So people who have high triglycerides also tend to have metabolic derangements like hypertension, insulin resistance for sure, hyperglycemia typically. All of those things have an impact on endothelial function and can exacerbate atherogenicity, so indirectly. So just to summarize, I see this as a three-pronged effect from hypertriglyceridemia. There's a direct effect of the lipoproteins. There's a potentially indirect phenomena from fatty acids from those particles on endothelium, and then the bystander phenomena of these patients who have hypertriglyceridemia also have these other phenomena that render the endothelium atherogenic.
So when we think about these two differential risks, the pancreatitis risk and the ASCVD risk, is there overlap? Are there any conditions where you see both?
Oh, for sure. So we talked about the ASCVD risk from triglycerides. The pancreatitis risk seems to be more directly related to the triglycerides. And so all kinds of lipoproteins carry triglycerides that potentially can trigger acute pancreatitis. The physiology of acute pancreatitis is not as well understood, I think, as atherogenesis. But, the prevailing theory is that, large triglyceride-rich lipoproteins, especially chylomicrons, which emanate from the gut, can create a sort of backlog in the pancreatic tissues, in the pancreatic capillaries, and ambient exposure to lipase from the pancreas can trigger some fatty acid release that triggers trypsin activation and pancreatic response just due to these high levels of triglycerides in the capillaries as they pass through. And once the trypsin's activated and the pancreatitis has started, it's a revolving door until you get rid of the lipoprotein. And so little different physiology has more to do with the triglyceride than with the lipoproteins proper. The overlap between these two conditions is in people who have chylomicronemia and other atherogenic lipoproteins like hepatically derived lipoproteins, VLDL, and remnant particles. And those patients will have severe or extreme hypertriglyceridemia, typically will have chylomicronemia, and their ApoB level, the protein that's found on all these, will be elevated as opposed to people who just have pure chylomicronemia who have low ApoB.
That segues right into our next section, which is your approach to hypertriglyceridemia based on the current guidance that's out there right now. AHA and ACC have put out some guidance, the Endocrine Society and ACE. There's a wonderful statement on triglycerides. It's an expert decision pathway that was published a couple of years ago. How do you go through the process from mild to moderate to severe to very severe in approaching your first steps? We'll get to prescription medication, but I want to talk about your thought processes first.
Yeah, I think it makes sense first to distinguish whether somebody has severe versus not severe. So you can use a 500 milligram per deciliter as your threshold for not severe. So if you start with the less severe, the more mild to moderate, you look at the triglycerides at less than 500, then you want to ascertain what their ASCVD risk is. So do they already have atherosclerotic cardiovascular disease? Are they diabetic, hypertensive? What other features do they have? Assess for secondary causes for why they have it, because some of those secondary causes may have an impact on their atherosclerosis risk in the first place. And they may certainly be targets for modification once we determine what we're going to do with that patient. But if I've determined that somebody has significant ASCVD risk because of those features present, then we're really starting to talk about ways that we can mitigate that risk. And, you're first and foremost, we're going to recommend dietary and other lifestyle measures to start working on this process. We're going to look for secondary causes for why their triglycerides are high. And we're going to, try to fix all the things that may be contributing to this. And then we're going to reevaluate them and see what kind of response they get. If we found them on that first day to be at very high risk for ASCVD, we can do all these things simultaneously. You can do the evaluation, you can make your lifestyle recommendations, and you can treat them as someone at risk imminently for ASCVD. If they don't seem to be at imminent risk, you can do it in a more leisurely pace and do it in a more stepwise fashion. And we can talk about the different pharmacologic interventions too. It's not that different when someone's triglycerides are over 500, but there's a slightly different emphasis on the diet and lifestyle modification. There's certainly going to be different dietary strategies depending on the height of the triglyceride level, because it really speaks to the origin of the lipoproteins that are abnormal. So, people who have triglycerides of 5,000 have chylomicronemia. Chylomicrons come from the gut. So you want to focus on managing fat in the gut. Whereas if their triglycerides are more mild to moderate and or less than 1,000 milligrams per deciliter and they have a high ApoB, those triglyceride-rich lipoproteins come from the liver. So you need to focus on reducing fat in the liver. So there's different dietary strategies when you're trying to manage this based upon whether you're talking about gut-derived particles versus liver-derived particles. And I have that in the back of my mind. And that's why distinguishing at that 500 milligram mark you start thinking more about the gut-derived lipoproteins, the chylomicronemia.
Yeah, I think that's a great way of thinking about it. And I think it's an example of why you're such a good educator and teacher, being able to distill pathways down to underlying physiology and pathophysiology. I've always felt is the best way to diagnose and then understand treatment pathways. And so diet and lifestyle obviously remain first line. And you can't, by the way, be successful with any subsequent pharmacologic therapy if people are not adherent to diet and lifestyle. Unfortunately for the folks with chylomicronemia, sometimes even strict adherence to diet doesn't work, and they're often accused of dietary non-adherence, which is one of the issues around the disorder. There's a lot of psychosocial issues that develop around this. But after lifestyle, what are your treatment options first for mild to moderate hypertriglyceridemia in the ASCVD risk reduction space? And then as we move on to higher levels, what's available to us with regards to pure triglyceride-lowering therapeutics?
Jamie, do you mind if, before I jump into that, we talk a little bit about syndromes?
Absolutely.
You and I love to talk about syndromes because I think this is where the real rubber meets the road for a lipid specialist. So it's worth recalling that if you think about the lipoprotein phenotypes that we all learned when we were coming up in basic fundamental lipidology, we talk about the Friderichsen-Levy-Lees classification of lipoprotein phenotypes, which many think of as passé, but I think is very useful when you think about things in terms of the physiology of the problem. So remember that, they classified lipoprotein abnormality, hyperlipidemia, based upon these Roman numeral classifications, type 1 through type 5. All of the abnormalities on that list are associated with hypertriglyceridemia, with the exception of type 2A, which is a pure LDL excess hypercholesterolemia. But all of the other lipoprotein phenotypes are associated with high triglycerides. And each of them has an association with a particular lipoprotein abnormality, either chylomicrons, VLDL, or remnants, or some combination of those with something else. So either one lipoprotein's in excess or two lipoproteins are in excess. So I like to think about those terms because if I can break it down that way, I know that there are particular phenotypes that are associated with syndromes. And then if I know the syndrome, I know what to expect for my patient, and I know what kinds of therapies are going to be useful. And I find that actually more useful than an algorithm based upon do they have risk, don't they have risk, and which drug to treat them with. Ultimately, it may still break down to a more simplified approach, but I like to think about these patients in this term because then I understand my patient's outcomes better. For our patients who look like they have pure chylomicronemia, a type 1 physiology, then, most of the time when we see that, we're really talking about an inherited condition called familial chylomicronemia syndrome. And, for those patients, as you mentioned, they have to follow a very strict diet. And now we have some specific medications that can impact that condition that we never had before prior to last year. So we have 2 drugs for FCS, that pure chylomicronemia syndrome, olezarsen and plozasiran. In patients who have chylomicronemia, persistent extreme hypertriglyceridemia, but who also have elevations in ApoB and maybe some other cardiovascular risk and secondary causes that are contributing to it, we think of them more along the lines of a type 5. They have chylomicronemia and VLDL excess, and they may not be the classic familial chylomicronemia syndrome, but they definitely have an inherited predisposition and usually some other secondary environmental factor that's driving this. Right now, access to those 2 drugs that I just mentioned to manage their chylomicronemia is complicated because those drugs are not FDA approved for that purpose, but there's certainly going to be some overlap in people who fit more along that second group that compared to the first group who may benefit from that kind of therapy. The other groups that we think about in treatment are people who have pure triglyceridemia due to VLDL. They don't have chylomicronemia, sort of a classic type 4 population. They don't appear to be at very high ASCVD risk either. And their cholesterol level is lower and their ApoB level is lower. They just have pure hypertriglyceridemia. They almost never get their triglycerides above 1,000. They can very well be managed with lifestyle modification. And because they tend to be at lower ASCVD risk, you oftentimes don't even need to use any pharmacotherapy. We have the highest ASCVD risk group, the classic 2B patients. So they can have triglyceride levels that look more like mild to moderate, sometimes severe, but they have very high ApoB levels. And these patients have lots of circulating atherogenic lipoproteins. They have a higher ASCVD risk than classic familial hypercholesterolemia, partly because they also tend to be more prone to have diabetes, insulin resistance, hypertension, and some other risk factors that drive this. But that's a phenotype that's particularly concerning. In those patients, you start with statin therapy, then you start using other ApoB lowering therapies. Then if you need additional therapy because of persistent hypertriglyceridemia, you would consider specifically like icosapent ethyl. And that has more to do with the ASCVD risk reduction rather than triglyceride lowering.
What I'm hearing for you, the most severe patients, the FCS patients, we're lucky enough now to have these two new agents that target the mechanism, which is essentially independent of lipoprotein lipase, so to speak. But that there are many other scenarios where there's a host of things that can be done for these mixed and overlap syndromes, from statins to fibrates. Do you use niacin much anymore for managing triglycerides?
Never.
Neither do I. And I think it's good to make that clear to people that in the lipid space, we don't use this anymore. Certainly not for patients that are at risk for diabetes or other issues. But there is a role for statins, especially with the type 2B patients that you've mentioned, familial combined hypercholesterolemia. And I think the role of ApoB in discriminating diagnosis, we don't have time to get into some of those categories. But as you and I have always said together, diagnosis is key, because diagnosis determines risk and diagnosis determines causality and ultimately treatment costs. Now that we've got these two new medications available, one fairly recently, just within the last week, I believe, it's exciting for us in the lipid space, but, we're lucky enough that there's still an evolving space where we live in, which is what's so exciting about lipidology. Anything new on the horizon that you're still interested and excited about when it comes to triglyceride management?
Yeah, I mean, those two drugs that we mentioned are ApoC3 inhibitor. ApoC3 is an important inhibitor of lipoprotein lipase. So we use an inhibitor of the inhibitor to enable the enzyme to work better. Turns out there's a bunch of other circulating inhibitors of lipoprotein lipase on lipoproteins and in just free circulation. Of the freely circulating, of course, there's an important enzyme system called ANGPTL. And there's several different ANGPTLs. There's 3, 4, and 8. There's already an ANGPTL3 inhibitor that's FDA approved for the treatment of homozygous familial hypercholesterolemia. That drug is called evinacumab. It's really, confusingly, not a triglyceride lowering therapy, right? It's for the treatment of LDL through a mechanism that's independent even from the LDL receptor. And so that drug is already FDA approved, but exclusively for that rare disease space. However, it doesn't mean that ANGPTL3 inhibition won't have a role in the future. I think there's some reason to think that it may be useful for people with mild, moderate, or even severe hypertriglyceridemia who don't have FCS. So that's a line of investigation that's still underway and that we're still in our adolescence with respect to that. ANGPTL3/8 inhibition, where dual inhibitor, also has a role, just beginning that line of investigation. And ANGPTL4 has a potential role as well for the treatment of mild to moderate or even severe hypertriglyceridemia for ASCVD risk reduction and possibly even some impact on diabetes development. But way too soon to start thinking about them as available therapies. I'm just looking into my crystal ball for the future as potential interventions for hypertriglyceridemia.
So, Dan, this has been a wonderful overview of a rather complex disease state. Hypertriglyceridemia comes in many shapes and forms and is oft misunderstood, I think, even within our own little world. You did a great job of going over the importance and the definition, why we think about it not only just for pancreatitis risk, but for ASCVD risk, and how there can be overlap. And so understanding the clinical syndromes and the phenotypes that are derived from the genotypic abnormalities that drive these conditions helps us understand risk for ASCVD and pancreatitis, and then also better understand the treatment modalities, starting with, of course, diet and lifestyle always, especially in this case more than anything. We've had a host of medications that have been somewhat useful in patients with mild to moderate disease and not really useful at all in FCS until ApoC3 inhibitors became available. But there's newer stuff on the horizon. And so that's one of the things that's so exciting about lipidology is that there's always something new around the corner. And for someone like yourself who does clinical trials also, it's certainly an exciting time to be a lipidologist. Any last thoughts from your end?
I share your enthusiasm. I think it's really fun to watch some of this unfold. I don't want to lose sight of the things that we already know work really well, that, there's some great dietary interventions and the impact of regular exercise. We didn't talk at all about incretin therapy and weight loss strategies for our patients who are at risk from complications from hypertriglyceridemia and other obesity-related problems. Some of those patients are coming back in, and all of the things are improved with weight reduction. Those are not really triglyceride-lowering drugs, but they certainly have an impact on many of our patients. And it's an exciting time. And the drug therapy and the non-drug therapy, there's a lot of room to help our patients who have these conditions.
Yeah, I think what I'll end with is something that we haven't mentioned, but both of us are uniquely aware of, which is that in lipid centers like yours and ours, we're lucky to be able to work with wonderful registered dietitian nutritionists that are very focused and well educated in the space. And they're such a key component to managing patients with triglyceride disorders, especially the more severe versions of the disorder. And so working within your team is so key and important. So Dan, I want to thank you for this wonderful and way too brief discussion. And thanks to our audience for listening as always. Please remember to take the post-test and do the evaluation at the end to receive the CME credit. And also please tune in for additional episodes within this series. In our next episode, I will be speaking with Dr. Ann Carol Goldberg about identifying and managing homozygous familial hypercholesterolemia.
Thanks again for listening to MedEd Talks Cardiology. CE credit can be claimed through mededtalks.com. For other episodes in this series, search for Lipid Legends Season 2.